Now you could do something called EMA binding test. Okay, that test will say whether it's a positive or negative, but the most commonly for the test, increase osmotic fragility test. Now, what is an osmotic fragility test? There's a special type of fluid, okay? There's a special pressured fluid. If I take a healthy red blood cell and I put it on that fluid, those red blood cells will not break because they are healthy. But if I take these patients' red blood cell and put it, it will easily break because there's a defect in ankyrin and spectrin, so the membrane is not strong enough. Is everybody clear, folks? So that's why increase fragility, osmotic fragility test, folks, okay? So that's the idea. They put that on a hypertonic solutions. Healthy red blood cell will not break. Only these diseased people will break, folks, okay? So that's the basics here. Now you tell me, how do you treat this patient? We cannot replace the membrane protein. We cannot do anything, right? But at the same time, do you really think this red blood cell is problematic? No, because they are carrying the oxygen and they're doing everything what they are supposed to. But the problem here is spleen that keep picking on them for a defect. So the only treatment is splenectomy. We have to remove the spleen so they stop picking on those red blood cells. Okay. Now it's very important. So splenectomy is the treatment here. And before the splenectomy, we have to give the 3 vaccines and then we remove it, folks. Okay. That's the key here. And this is the second disease we are studying so far in hematology, where the splenectomy is the treatment, isn't it, folks? What's the disease we studied yesterday that splenectomy was the treatment? What is it? What is it, folks? Don't type all the platelet disorders we learned. It's ITP, folks. Okay. Because in ITP, you have antibody against platelets. So when they go to spleen, they keep picking on them, isn't it? So it's ITP. All right. Early morning, it's okay. We need some caffeine to go in, right? It'll come out. All right. So that's hereditary spherocytosis, folks. Okay. Is everybody clear with the hereditary spherocytosis? So to recap, it's a defect in the membrane of the red blood cell, even though they are 100% functional, but spleen keeps picking on them. So we remove the spleen. Is everybody clear, folks? All right. Now, next disease, paroxysmal nocturnal hemoglobinuria. So we talked a little bit about this on immunology, and I said we're going to talk a little more deep on hematology. So let's start step by step. Now, let's say I have a blood vessel. The blood vessel has red blood cells. This red blood cell has a marker. What's a red blood cell marker? CD55 and 59. Remember that? CD55 and 59. Now, let's write the steps. Let me write first and you see it and then you copy, folks, okay? So you know where the problem is. Every time we sleep, okay? Every time we sleep, our respiratory rate decreases. When we sleep in the night, we breathe slowly, folks. When we reduce the respiratory rate, we accumulate carbon dioxide in the lungs, okay? We accumulate carbon dioxide in the lungs that will cause respiratory acidosis, because anytime you accumulate carbon dioxide, it's an acidotic, okay? Now, respiratory acidosis activate complement. So not respiratory acidosis, any acidotic environment will activate complement. What's that complement will do? It will go in the blood and they started looking for any foreign antigen. Is everybody clear, folks? Now, so let's say when I slept last night, my complement was activated. They go and make sure there is no aliens in our blood. Does that make sense, folks? So they went and make sure there is no foreign body. All good. That's a normal process. Imagine if I don't have that CD55 and 59. CD55 and 59 is the only receptor that identify red blood cell, because red blood cell don't have a nucleus to get genetic information. Is that clear, folks? So now if you don't have CD55 and 59, complement will think this is a foreign body because there is no marker. Is that clear, folks? So when they think it's a foreign body, they're going to attack all the red blood cell. Because it happens in the night when we sleep, we call paroxysmal nocturnal hemoglobinuria. Okay, this is the step. Now, theoretically, it happens when you sleep, so not necessarily night, right? If somebody sleeps during the daytime, it will happen on the daytime. The idea is when the complement get activated. Is everybody clear, folks? All right, go ahead and write it down.
Increased IO2 meaning inspired O2.
Say it again.
Increased IO2 meaning inspired
No,
O2.
it's CO2, carbon dioxide. When we reduce the respiratory rate, we are breathing slowly. That means we keep more carbon dioxide in the lungs. All right, so now if you go see here, now you could see hematopoietic stem cell mutation, increased complement-mediated intravascular hemolysis. Look at that, because complement cannot enter the spleen. They have to be in the blood vessel. That's an intravascular hemolysis. Is that clear, folks? Very good. Especially at night. Now you know why it's okay. Because they are missing the CD55 and 59. That's all it is, folks. They're missing the CD55 and 59. And I mentioned in immunology, another name for it, decay accelerating factor. That's a name for CD55 and 59. Now, people can have pancytopenia, venous thrombosis. I remember mentioning Budd-Chiari syndrome. The portal vein thrombosis can happen during paroxysmal nocturnal hemoglobinuria and stuff. Okay. Now, because the attack happens in the night, in the morning, they will have red urine because all the bilirubin and everything is releasing from, okay, hemoglobin and everything, folks. When you do the flow cytometry, they will be negative for CD55 and 59 because they don't have that, folks, okay? That's the thing. Now, if you ask me, even though these red blood cells don't have the receptor, do they do their job? They do their job 100%. They carry their 4 oxygen molecules. So you can't really do anything to them because they do their job. So what should we do? We have to inhibit complement as a treatment. Is that clear, folks? Now we studied eculizumab is the medication that's monoclonal antibody that blocks the formation of MAC. In order to block the formation of MAC, we need to block C5. If you block C5, there is no C5b. Without C5b, there is no MAC formation. Is that clear, folks? Okay, so that is eculizumab. Okay, any question in paroxysmal nocturnal hemoglobinuria? No. All right, let's go to the next one. You see again a review here from biochemistry. G6PD deficiency. What did we say about G6PD? You need the enzyme G6PD to form NADPH, right? We said HMP shunt in biochemistry, you need NADPH. NADPH keep the glutathione in a reduced form, isn't it, folks? And when you don't have NADPH, glutathione can become oxidized form if you are exposed to some stress. Is that clear, folks? So the same disease we talked about. Now, decreased G6PD, decrease NADPH, reduced glutathione, and now your red blood cell is susceptible for oxidant stress. If they were to expose to fava beans and all these things, highlight sulfur drugs, The exam loves that. They say patient had some sort of infection and patient was prescribed TMP-SMX. TMP-SMX is an antibiotic which is full of sulfur drugs. And the patient comes back after 3 days. That's because of the effect of this, folks, okay? Now look at this. It causes extravascular and intravascular. So this is one of the example. You could have intravascular or extravascular hemolysis. It can happen anywhere. Okay, so that's a unique disease to have this anywhere, folks, intravascular or extravascular. Patient comes with back pain. They will have a back pain. Hemoglobinuria a few days after the oxidant stress. See, that's important. If they have the effect today, if they have the attack today, it will take like 2 to 3 days for them to have the red urine, folks. Okay, so that's that. And then we have a lab that we could check for decreased G6PD activity. And the Haynes bodies. Haynes bodies are oxidized hemoglobin. Okay. Now we reviewed this pretty much good in biochemistry, and this is a repetition. I think the only new thing that we learned today, it's an intravascular and extravascular hemolysis. Everything else we should already know that, folks. Okay. So that's G6PD deficiency. Is everybody clear? All right. Now look at the next one. Pyruvate kinase deficiency. What does pyruvate kinase do? Convert the phosphoenol pyruvate to pyruvate. Pyruvate goes into TCA cycle and stuff. Red blood cell don't have any, mitochondria or anything, so they depend on ATP from outside source. Okay. When you have a pyruvate kinase deficiency, can you do TCA cycle? Yes or no? All right. So that's something we're going to have to learn. Let's do glycolysis here. Somebody tell me verbally, step by step. Guide me. Somebody, Wayne, go for it. Glucose.
Did you say my name?
Yes.
Oh gosh. Okay. You said with the glycolysis?
Yeah.
Okay, glucose to glucose 6-phosphate.
Okay.
And then fructose 6-phosphate. To go from glucose to glucose 6-phosphate. Do you want the enzymes or?
No, you don't need the enzyme. Go to the steps.
Okay, fructose 1,6-bisphosphate after. And then after that, you do your you got.
So after fructose 6-phosphate, what do you get first?
Fructose 1,6-bisphosphate? No?
Does everybody agree with her?
Fructose 2.
6. Oh,
You get 2,6-phosphate, and then on the other.
2,6-bisphosphate, that brings the fructose 1,6-bisphosphate.
Yeah.
Remember that?
okay.
Continue. Then we
Then
divide
you get
two.
your G3P and then your DHAP.
Okay. This is the glyceraldehyde. So we have a couple of steps, skip, and we get to PEEP. And then the final one is pyruvate. Is that clear, folks? Now, why I wrote there's a reason behind. The pyruvate kinase is here, right? Now, when you have a pyruvate kinase deficiency, everything backs up to phosphoenol pyruvate. Agree, folks? That will back up to glyceraldehyde. That glyceraldehyde will go on a side pathway, which I don't have the space. 2,3-BPG. 2,3-BPG. So anytime you cannot complete the last step of glycolysis, you increase in 2,3-BPG. Do you see that? Okay. Autosomal recessive, pyruvate kinase defect, decrease ATP, so the red blood cells are rigid. Extravascular hemolysis. Why extravascular hemolysis? When the red blood cell goes into the spleen, they are rigid. They get removed. They're showing attitude. Okay. Now, what is the effect of increased 2,3-BPG? We studied increased 2,3-BPG gives you right shift. Oxygen hemoglobin right shift. Look at that. Decreased hemoglobin affinity for oxygen, folks. That's what you wanted to connect here. Okay. Anytime you cannot complete the glycolysis, you get 2,3-BPG. Is everybody clear, folks? All right. This is a hemolytic anemia in newborn, right? People in newborns are the one who gets it, folks. Okay. Very good. That's pyruvate kinase deficiency. Is everybody clear? All right. Now,
Dr. Rowe, could you go back to the picture?
which one?
I just needed to get the pathway. Okay, that's it. Thank you.
Now, next one, sickle cell anemia. This is a big disease. Okay. Now, let's talk about sickle cell anemia. It's a point mutation of beta globin gene. There's a single amino acid substitution. So what does that mean? One of the amino acid is replaced. Now, if you see, folks, amino acids are the one that's part of your DNA, right? DNA and RNA. So when one amino acid changes, it changes the whole transcription to something else, folks, okay? Now, if you see here, instead of glutamic acid, these people get valine. So glutamic acid is what's supposed to be there, but they are getting valine instead of that. Now that makes a completely wrong protein, folks, okay? It causes intravascular and extravascular hemolysis, okay? Intravascular and extravascular. Now, so far, 2 diseases we studied that has intravascular and extravascular, that's G6PD and sickle cell. Is that clear, folks? Okay. Now we have a wrong protein. So what will happen is, so let's say this is the normal shape of the red blood cell. What's the normal shape is called? Biconcave, right? That's the shape of the red blood cells. Because of a wrong protein, what's going to happen? The cell is normal, but when you are exposed to hypoxia, when the red blood cell is exposed to hypoxia, they will change the shape and they would start sickling like that. They will start changing and it will become hypoxic and then will be sickling. So what does that tells you? Sickle cell people are absolutely normal as long as they are not exposed to hypoxia. Is that clear, folks? They are perfectly normal unless they're exposed to hypoxia. Now, look at this pathogenesis. Low oxygen, high altitude gives you low oxygen, acidosis, those are all start precipitating, folks, okay? That precipitates sickling, okay? That is the bottom line. Now, sometimes students think people with sickle cell disease, they're at risk all the time. Absolutely not. They will have a normal life unless they're exposed to hypoxia or dehydration. Okay, as long as they make sure no dehydration, no hypoxia, they wouldn't have any problem. Is that clear, folks? All right. Now, what will happen? Of course, they will have anemia because they are sickling. I want you guys to highlight this word, vaso-occlusive disease. Now, let's talk about this in a big picture. So let's say this is one blood vessel, right? This goes into 2 branches, okay? Let's say this blood vessel go to, this is organ A, this is organ B. They're going to different one. Normal red blood cells. No problem, they are going. When this patient started having hypoxia, what will happen is these red blood cells will start to become sickling like that. When they become sickle, they almost behave like a thrombus and they will start blocking the blood vessels. When they block the blood vessel, we call it vaso-occlusion. Is that clear, folks? So that vaso-occlusions only happens when they are exposed to hypoxia or dehydration. And when they are blocking, do you think the organ B will get any oxygen? No oxygen, okay? That's the whole pathology of sickle cell. So when people have a sickle cell disease, you cannot tell which organ will be affected. It's their luck and their timing. That's all it is, folks, okay? Now, sometime they will block a blood vessel that goes to the head of the femur. If they block the blood vessel to the head of the femur bone will go necrosis, so we call it avascular necrosis. Sometimes they will block the renal artery, the kidney will die. Sometimes they will block the spleen will die. Those people still survive, but sometimes it will block the heart or chest. We call that acute chest syndrome, they die. When they block the blood vessel to the heart or lungs, they die, okay? That's the sad part. Now, if you see here, folks, that vaso-occlusive diseases, right now, they put everything here on the side, look at that. If they block the splenic artery, the spleen will die. So we have autosplenectomy, which means the patient has the spleen inside, but it's not functioning. Is everybody clear, folks? Okay. Now, splenic infarction can happen. They could get bone infection, osteomyelitis. This is something that they've been asking for the past 20 years in step 1. Salmonella is the reason for the osteomyelitis in people with sickle cell. Look at this painful vaso-occlusive crisis, dactylitis. That means the blood vessel is blocked to the hand. So all the fingers are swollen, folks, okay? Sometimes it blocks the blood flow to the penis. They have priapism. Acute chest syndrome, highlight that. This is the bad part, folks, okay? It happens. It's pretty much you cannot do anything. Avascular necrosis, stroke. If it blocks the blood vessel to the brain, you will have a stroke. If it blocks to the kidney, you have a kidney necrosis. So, that's why you don't know until it happened that day which blood vessel is going to get blocked. Is that clear, folks? It's all their luck, okay? That's the idea. Now, while they have sickle cell, if they were to get parvovirus, they get a crisis. Always remember, when you have one disease and another disease happens on top of it, it's always a severe case, folks, okay? So that's sickle cell anemia. Does everybody understand the problem? Okay, so as long as you keep them with a good oxygen level and a good hydration, nothing will happen, okay? Now, newborns are initially asymptomatic is because newborn has a fetal hemoglobin. This sickle cell disease do not affect fetal hemoglobin. They don't affect the fetal hemoglobin, okay? So which means for the first 6 months, they shouldn't have any symptoms and the problem starts afterwards. Now, people with sickle cell, they are resistant to malaria. I'll explain that later. Now look at that sickle cell crescent shape RBCs. You could see that. Look at this. That's a beautiful picture of a sickle cell. How the cell is sickled, folks, okay? Crooked on skull X-ray due to marrow expansion. Let's talk about this marrow expansion a little bit. Let's draw. Okay, I want you guys to think this is the bone, okay? So think that's the bone. This is the thickness of the bone, okay? So that's a bone thickness. I put B there. This is your bone marrow, M. So small part inside the bone is your bone marrow. Is that clear, folks? That's normal. Now what happens when people have a sickle cell disease? The erythropoietin will go up. Why erythropoietin will go up? Because of hypoxia. Hypoxia always stimulates erythropoietin. Is everybody clear, folks? That erythropoietin will go to the bone and start stimulated production of reticulocytes. Agree? Now the bone marrow need more space to produce red blood cell. What bone marrow is going to do? They're going to start taking more space of the bone to expand the bone marrow. Okay, so when they start taking more space to expand, what has happened? The thickness of the bone has reduced, isn't it, folks? Why the thickness of the bone is reduced? Because the marrow want to expand inside. That's the key, folks, okay? That's what we call bone marrow expansion. So that when you take a scanning of those bones, it will look like very weak bones because it's not dense anymore. Is that clear, folks? All right, so that's sickle cell anemia. Now, how do we treat? The treatment is hydration. That's your number one task. And then we try to prescribe hydroxyurea. That's a medication that increases fetal hemoglobin because we know fetal hemoglobin is not affected. So the more fetal hemoglobin they have, the better it is. So that's why we give hydroxyurea and hydration. Okay. Now, how do we diagnose? Electrophoresis. Simply, we would do an electrophoresis, it will pick up. So that is your sickle cell disease. Is everybody clear, folks? So what are the things to remember? Sickle cell is a single amino acid substitution. Instead of glutamic acid, you have a valine. That changes the whole thing. And when they're exposed to hypoxia, the cells started sickling. When they sickle, they cause vaso-occlusive disease. And that's a problem, okay? So that's sickle cell. Now, there is a mild version of sickle cell, what we call hemoglobin C disease. Now, what is hemoglobin C disease? Same thing. Glutamic acid is replaced by lysine. So what about sickle cell? Valine. This is lysine. Is that clear, folks? So this is a little bit mild. only extracellular hemolysis only happens there. Now, just to remember, it's a milder version of sickle cell. That's all to remember that, folks, okay? So that's a milder version. These are all intrinsic hemolytic anemia. If you see all the disease we just studied, it's all problem within the red blood cell. Nothing came from outside. Is everybody clear, folks? So if you have a defect of spectrin, that's a red blood cell problem. It didn't come from outside. Okay, so they are all intrinsic hemolytic anemia. Now, if you go here, look at this. It's a beautifully separated. There's a membrane defect. There's an enzyme defect. There's a hemoglobinopathy. Look at this, folks. Hereditary spherocytosis. What's the problem? Membrane defect of ankyrin and spectrin. Paroxysmal nocturnal hemoglobinuria. What's the problem? Membrane receptor CD55 and 59. See, they're nicely divided into membrane defects. Then you have enzyme deficiency. G6PD is an enzyme deficiency. Pyruvate kinase is an enzyme deficiency. Then the last one. Red blood cell is made up of two things. What are the two things? It's made up of a protein and heme. That's why we call hemoglobin. Heme mean iron, globin mean protein. Is that clear, folks? So you could have a diseases of a heme group or disease of a protein. Sickle cell and hemoglobin C, those are all diseases of protein, not heme. Is that clear, folks? So you should know that's the diseases of protein, just to give a big picture. Okay. So that's your intrinsic hemolytic anemia. All intrinsic hemolytic anemia, we just talked about it. Is everybody clear, folks? Okay. Now, let's go back here. So there you go. So that completes your intrinsic hemolytic anemia. Any questions for me in this page? No question. All right. Let's go to the next page. Now we're going to start looking into extrinsic hemolytic anemia. Extrinsic hemolytic anemia means the problem is coming from outside. Okay. So the problem is outside the cause. I want to start with the easy one first, so that can make a good sense. Infection. Look at the infection, folks, especially talking about malaria. What are the species of malaria, you guys know? How many species are there, first of all? There's about 4, right? There is 4. Let's talk about a little bit of malaria disease so you get the picture. So we have a blood vessel. Inside you have a red blood cell. When malaria comes, there's 4 species. Now, what happens, folks, malaria comes and they live in 2 places. They live in liver and they live in red blood cells. There's a cycle called schizosome gametogony, okay? There's a cycle. They live in the liver and red blood cell. What they do, they go inside the red blood cell and they multiply inside the red blood cell. In another word, they make out inside the red blood cell. Is that clear, folks? They multiply inside the red blood cell. That's fine. Once they multiply, 1 malaria become 100. How do they come out? They have to rupture the red blood cell to come out. Does that make sense, folks? They have to rupture. When they rupture the red blood cell, all the malaria is released outside. When they come outside, what will happen? You get the symptom of fever. Isn't it? Fever is very specific for malaria. There's a cyclic fever, isn't it, folks? Some malaria people get fever every 48 hours. Some malaria people get every 72 hours, isn't it? Why? Some malaria replicates in 48 hours. Some malaria replicates in 72 hours. Every time people get fever with malaria, you should know they are breaking red blood cell at that moment. Is that clear, folks? Now, there is one species that is irregular. They don't follow this 48 or 72-hour fever. They come irregularly. Type it up. What's the name of that irregular species, what we call in malaria? Type it up. Student from Asia cannot miss this question because for them, malaria is like buying candies there. Come on. Tanuja, what is it? Not malaria, falciparum. The Plasmodium malaria still follow the cycle. Only the falciparum is considered irregular, okay? Falciparum, make sure you guys write that down. So what is that falciparum? They can cause fever any random time, folks. That's why we call it irregular and hard to diagnose because they don't follow the normal cycle, okay? So that's that. Now you see here, how did we break the red blood cell? Is it a problem within the red blood cell or the problem came from outside? It problem came from outside. Infection came and break it, folks, okay? Same thing with Babesia microti. They come and break the red blood cell. Both are good example from outside. Is everybody clear, folks? All right. Now let's go next. First, let's start with, Robin's pathology, they keep both same. Whether it's a microangiopathic or macroangiopathic is the same. Both are happening within the blood vessels, folks, okay? Let's take a look at microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia is considered as you have a breakdown of red blood cells within the blood vessel. That's why it's called microangio, within the blood vessel, folks. You are breaking down red blood cell within the blood vessels. So look at this. RBCs are damaged when passing through obstructed or narrow blood vessels. Now, of course, because it happens in the blood vessel, it has to be intravascular, isn't it, folks? All right. Now, we've seen it in DIC. We've seen it in TTP. Why do we see it in TTP? What are the two important things we needed to diagnose TTP? Type it up. Two criteria to diagnose TTP. What are the two criteria to diagnose TTP? Thrombocytopenia and microangiopathic hemolytic anemia, isn't it? These are the two features. Now, when you have a TTP, we studied yesterday, they make a clot. So the red blood cell go hit the clot and they break it. That's why they have that, okay? Same thing with SLE, HELLP syndrome and all these things, hypertensive. So they all break that, folks, okay? Now, next one, what we call macroangiopathic hemolytic anemia. When we say macroangiopathic hemolytic anemia, what they are saying is a little bit bigger. So let's say a patient had a prosthetic heart valve, aortic stenosis. I think aortic stenosis is a good example. When you have aortic stenosis, aortic valve is full of calcification. That means it's like a metal valve. Every time when the heart pumps, blood comes out of aortic valve, in that force, it's going to hit the aortic valve. Is that clear, folks? When they hit that aortic valve, they break. Same thing with prosthetic heart valve. They used to do heart valve in platinum. It's a metal heart valve they put. Because of this issue, they change it. Nowadays, the heart valve is a synthetic tissue. It's almost like a human tissue. So they don't hit and they don't break, folks, okay? So when you put a metal valve, this was the problem. So it's a mechanical destruction. Both will give you schistocytes, okay, which is your helmet cells. That's all it is, folks, okay? Now, that's micro and macro. You see, there's nothing wrong with the red blood cell. The problem is outside. They're hitting and they're dying. Is everybody clear, folks? Okay. Now, the last one of extrinsic hemolytic anemia, a little trouble one, autoimmune hemolytic anemia. Autoimmune hemolytic anemia means there is an antibody against red blood cells. Okay. There is an antibody against red blood cell. What is the name of the test we do to find if there's an antibody against red blood cells? Coombs test, isn't it, folks? Now is the time to learn how to do Coombs test. Okay. Now, you have to go back to the front because they moved it there, right there. Go to page 418. Okay, now let's talk about Coombs test. Here, what we're going to learn how Coombs test is done, folks. Okay, so listen to me carefully. There are two ways to do Coombs test. We have a direct test and an indirect test. It's just a two different way to do it, but the results will be same. If you get a direct Coombs test positive, your indirect will also be positive, folks. Okay, you will never get one is positive, the other one is negative. No, it never works. Now let me explain one first. Now, there are two ways to do that. First one is direct. Whenever we say direct, we are literally taking patient's red blood cell, okay? Patient's red blood cell. Now, that patient red blood cell has antibody. You see, I'm circling. These are all antibody already attached to patient's red blood cell that's not visible to our naked eye. Is that clear, folks? We cannot see it on the naked eye. So when I take the patient's red blood cell, in the lab, I have to give another immunoglobulin antibody we call anti-antibodies. Okay, so if I were to do this separately, let's say I have a patient A and patient B. I took both of their red blood cell, patient A, patient B. Patient B has antibody attached to it. Patient A don't have it, but I don't know that because those are not visible to naked eye. Is that clear, folks? So I take patient's red blood cell. In the lab, I'm going to add another antibodies, artificial antibody. I'm just going to write artificial antibody. So I'm adding an artificial antibody. Is everybody clear, folks? I'm adding an artificial antibody. So when I add an artificial antibody, we could say antibody to antibody. Is that clear, folks? Now, which one do you think will bind easily, A or B? B will bind it easily. Why? B already has this antibody. This will bind to this very easily. So they will cause agglutination. That means they clamp. A will not, because anti-antibody cannot bind to red blood cell directly. They have to have an intermediate. Is that clear, folks? Now, if you see the book, they are only showing one. Patient has a red blood cell, which already has an antibody. And when I add artificial antibody, you could see it's a positive results because they're agglutinating. Is that clear, folks? Here, this will be negative. For us to negative, it shouldn't have any antibodies. Is that clear, folks? So the picture is not properly complete, but if you understand this, you know what's that. Does everybody understand the direct Coombs test? So direct Coombs test, we are picking literally patient's red blood cell. When we take the red blood cell, we don't know whether it has antibody attached to it or not. Is that clear, folks?
So the antibodies that are already present on the red blood cell, and then when you give them, they come together.
Yeah, they come
Right.
together.
So and then in the B, because they don't have the original antibody,
No,
the other one
he has original antibody here in red blood cell.
they do.
They do. That's what I put. 2 antibodies right here.
But like on the result, you said it comes off
Where?
on the other picture. Like
No,
on
no, no. So
the
ignore that
side.
picture. Look at this picture.
the
Look at this picture first. A has no antibody. B has antibody. Now, both people I'm giving artificial antibody from outside. Only the artificial antibody can bind to red blood cell if they already have a pre-existing antibodies. Make sense?
Okay.
Okay. So here, agglutination, which comes together, will happen only if the patient also has their own antibodies. A will not come because the patient don't have their own antibodies. Is that clear, folks? That's direct Coombs test. Anybody still have a question in here? Okay, so we do direct Coombs test. See this picture, here they are showing negative, but they don't show a red blood cell that doesn't have an antibody. So that's why I say the picture is incomplete, okay? All right, so that's direct Coombs test. Now, indirect Coombs test. The same thing, but we are doing indirectly. Now, you have to be careful with me here. Indirect Coombs test means what I'm doing, instead of taking patients' red blood cell, I'm taking same patient's serum, not the red blood cell, their plasma fluid. If I take this patient's plasma fluid, the same patient A and B, A won't have anything, B will have antibody. Do you guys agree? A won't have anything, B will have antibody. Now, if I want to know if they have antibody or not, in the lab, I have to give two things. I have to give red blood cell plus the artificial antibody. Is that clear, folks? I have to give red blood cell plus artificial antibody. Why do I have to give red blood cell? Because I didn't take patients' red blood cell, I took patients' serum. Is that clear, folks? Now tell me, A or B, which one will agglutinate? B will agglutinate because they have all three things. Is that clear, folks? In order to get a positive Coombs test, you need three things: red blood cell, patient's antibody, and artificial antibody. Is that clear, folks? So here, B will be agglutinating, A is not. So everybody clear, folks? So the way we use direct and indirect. Direct means I'm taking patient's red blood cell. Indirect means I'm taking patient's serum, just the plasma. Is everybody clear, folks? Whether you take direct or indirect, the results are the same. Now, don't ask me, when do we do direct, when do we do indirect? Only hematologist knows that. They will do according to the situation. Sometimes they do both to confirm that we don't use something. It's all about the lab, we don't need to worry. But the idea is, example not ask you how Coombs test is performed, but you should know how it's performed. So when you read a question, if a question says patient has a Coombs test positive, that tells you you have antibody against red blood cells. So everybody believes. That's the idea. That's it. But you need to know this, how it's done. Otherwise, you will have a hard time with test to seeking. Like sometimes test to seek students come to me and ask me to explain the Coombs test, because if you don't learn here, it will hunt you there, folks. Okay. So is everybody clear with direct and indirect? Okay. I repeat one more time. Direct, we take patient's red blood cells and just mix with artificial antibody. Indirect, we are taking patient's serum and mix with the artificial red blood cells and artificial antibodies to see if they are working or not. So this is a positive test and this is a negative test. Is that clear, folks? All right.
I have a question. So generally speaking, when you use the word serum, that always excludes the red blood cells?
Yes.
Yeah.
Okay. Now, the serum, it depends where the answer is like you remember when you were going to an endometrial serum osmolarity and urinary osmolarity. Yeah, I'm talking about the concentration of the serum. We do have red blood cells in there, but they don't participate in the concentration. That's exactly, yeah. Now, that's the Coombs test. So everybody clear, folks? All right, let's go back. Now let's go here. In this autoimmune anemia, look at the Coombs test is positive, which means there is an antibody against red blood cells. There are two types. One, you should know when we say warm, it's IgG. When we say cold, IgM. That's fact. You have to know that. Warm IgG, cold IgM. Okay. Warm IgG, cold IgM. So there's an antibody. So when we say warm, it's IgG, so it's extracellular hemolysis. So I'll keep an eye. We see with SLE, CLL, subset. Now, you don't have to memorize everything by heart here. All you need to know, autoimmune can times more important than remember what antibody for that. IgG for warm and IgM for cold. If you look at the cold IgM, complete analysis of red cell agglutination, and then there's an extracellular hemolysis. Cold exposure to cold. When the exposure to cold, this can happen. Okay. Now, very basic, just keep like that. And then the treatment we could use steroid, and then nothing works spleen because spleen is key thinking, right? This is a certain disease that is spleen is treatment, so be careful. So that is your ordinary, so nuclear source. All right. So now if you go back to this chart, we have literally complete all of this in this section. That means you should be able to write that chart without looking. That chart has to come into your memory, folks. Okay. There's no way you can question like this chart is not from your eye. The image is remembering what they say. For example, if I am looking at the hematology question, even now after teaching my 9 years, as soon as I see hematology questions, this chart comes in from my eye. Because that's how your brain should coordinate and organize it, right? Otherwise, you will be in trouble with so many options and stuff, right? Like it's like when I see a question, my eyes scan for MCV. If they don't give MCV, it's going to be a little hard, and I look for different things like this chart. Okay, so you should be able to write this. It's not hard. Take a piece of paper, except my microcytic. See if you can write everything else without looking. If you miss it, okay, but don't look at it. I can write. Divide by microcytic, normocytic, and macrocytic. Start with macrocytic and then come to normocytic. Coming? If you miss, it's okay. You know, nobody become perfect on the first time. I wrote that chart like 10 times when I studied. I literally did. When I say 10 times, don't think that I'm just saying for the sake of it. I actually do. When I study, all I keep it is a white paper and pen. That's all I buy, nothing else. Because I keep writing again and again, because writing will get into your memory, right? That's okay. So now keep writing after the class few times, folks, that comes. Okay. But when that chart is in your memory, in front of your eye, you will enjoy it. See, that's important when you go to the hospital or when you see, you know, when I tell the students, when you study for these things, don't just study as a theory, study as that you are learning to your knowledge, right? If you're in the hospital, you're looking at a note, it says Coombs positive. When you know what it is, the whole world opens up in your mind, what's happening on the patient. Okay. I see a lot of students go for rotation. They say Coombs positive, have no idea what's happening, Coombs positive. Okay. Then what happens? You just stand there and watch. Nothing. You don't know what happens. You don't know what the doctor is ordering and what's is happening, right? About 4 years ago, I used to have students doing rotations. And it's when they know what's happening, like imagine we finish endocrine, right? If you are dealing with a thyroid disease patient, isn't it your brain will go nicely and see what's happening with the patients? So that's why when you study for knowledge, folks, okay? And tomorrow you become a physician. If you make a mistake, you know, I always tell people, you don't think about it until you make that mistake. If one person dies, it's because of you. Some people live, but most of the people cannot live with that guilty, or you will live with that guilty forever. You can't even imagine now because you guys never did that. Does that make sense, folks? It's not easy. Every day you come and go to sleep, you will think about it because one life is lost because of your mistake. And, you know, we get mad, right, when we go to hospital. Imagine if you take your kid and the doctor is taking a look at your kid and the doctor doesn't know what they're doing and they make a mistake on your kid. You wanted to kill that doctor, isn't it, folks? I wanted to cut them into pieces, like 12 pieces. I will do it. Now, the reason I'm telling is, put thinking that way. So that's how other family, other patients look at you guys, right? So for that, we need to really know the medicine, folks, right? It's like sometimes I have people calling me for certain diseases. I tell them, if I don't know, go to that doctor. And they ask, oh, you've been doctor for this many years. How come you don't know? I said, simple. I'm not a God. I only know certain things. Go to these people. Oh, no, because you know why? Sometimes I know what's exactly happening, but I'm scared because I'm not 100% sure. If I don't know 100% sure, I always say no, because why? This is not a building, folks. If it's wrong, you could break it and rebuild it. If something goes wrong and that person dies, I don't think I can live with it. Okay, so that's why when you learn, think in a way that you learn so you know it, then you don't make a mistake. You know, that's very important. I met few doctors who made a mistake and I talked to them and I really feel bad for them because sometimes mistakes happens. It's like, you will be like, it's a one simple thing that you didn't think and you can't, you know, blame it, but it happened, right? That's the idea, folks. All right, now let's go back here. Now, where is the chart? So we finished all of them, but let's go for microcytic anemia, folks. Okay, next, microcytic, that's the last one. Look at this, it's beautifully done here. It will be very easy. Let's clean this up a little bit. When you say microcytic, it's less than 80. And as I mentioned, red blood cell has two things, protein and heme. Now, if you see here, whenever you have a problem with protein, we call it thalassemia. Whenever you have a problem with heme, you have this disease. We already covered this under non-hemolytic, so we only have to talk about iron deficiency and lead poisoning. Is that clear, folks? All right. Thalassemia, iron deficiency, and lead poisoning. Those are the disease we have under microcytic. Now, unfortunately, we cannot just study that. We need to learn how heme synthesis works. let's go find this page. This is the last biochemical pathway for metabolism that we need to learn, folks. It's kind of little, I would say the word boring because the words don't make sense, but we have to go through it. Okay. Now, I mentioned something about this in biochemistry. Heme synthesis happens in mitochondria and cytoplasm, both. I mentioned it starts in mitochondria, goes to cytoplasm, and then it finishes in mitochondria. Look at that. First step and the last step happens in mitochondria. Is that clear, folks? First step and the last step happens there. What are the 3 cycles totally that happens in both places, mitochondria and cytoplasm? Type it up. 3 cycles, including heme synthesis. Heme synthesis, urea cycle. Those are good answers, but somebody write PDH dehydrogenase. That's a part of a pathway. What pathway is that? What is it? TCA cycle. Okay. TCA and glycolysis is also part of it, folks. Okay. And of course, gluconeogenesis. It starts in the cytoplasm, enter the mitochondria, and then comes back. Isn't it, folks? All right. Very good. Now, let's talk about a heme synthesis. This is very important. Heme is iron. How do we form that? We get succinyl-CoA. You should know that's also from TCA cycle. Joins with glycine, okay? Succinyl-CoA joins with glycine. With the help of this enzyme, ALA synthase. Look at that. ALA synthase is a B6 dependent. We form ALA. Aminolevulinic acid, that's what called ALA, folks. Okay, we form that. Once we form ALA, ALA become porphobilinogen by ALA dehydratase. Where students make mistake is here. This is ALA synthase, next one is ALA dehydratase. It's the same enzyme, 2 different words, right? One is a synthase, another one is dehydratase. Once you get porphobilinogen, then you get hydroxymethylvaline with porphobilinogen deaminase. I know these names are hard to pronounce and type, but we have to get used to it, folks, okay? Hydroxymethylvaline. That become uroporphinogen 3, which become coproporphinogen 3 by this decarboxylase. Don't worry, if the name doesn't come, you have to practice, okay? Now, finally, you get protoporphyrin that become heme by ferroketolase, folks. Now, 2 enzymes that you can never forget in your life is this and this. So if you remember that, that's kind of fair enough at this point. ALA dehydratase and ferroketolase. It's not hard to remember, folks, okay? These are 2 enzymes that's so important because they both are affected in lead poisoning. Okay, they both are affected in lead poisoning. We'll talk about that, but this is the heme synthesis pathway. This is how we get heme. Is everybody clear, folks? Okay, now, one of the key things, here they have their own diseases. Let's kind of go through one of them. I want to talk about these 2 diseases. Almost 1 question I expect in your exam out of these 2, okay? First, let's talk about acute intermittent porphyria. Acute intermittent porphyria is a problem with this enzyme. Look at this, folks. Porphobilinogen deaminase. When you have a porphobilinogen deaminase deficiency, you're going to back up this. Is that clear, folks? So you're going to back up that. Look at this. Porphobilinogen deaminase, and you are backing up porphobilinogen. Is everybody clear, folks? Look at the symptom. Painful abdomen, port wine colored urine, polyneuropathy, psychological disturbances, and precipitated by some factors. All these symptoms, you're not going to miss it. I'll show you a question. You will pick it when you see it. So that's acute intermittent porphyria, folks, okay? acute intermittent porphyria. Now, nobody will miss this question. You guys will get it because it's easy. Okay. Now, what type of question they ask? They say, what's the treatment for this patient for acute intermittent porphyria? Look at this, hemin and glucose. If you give hemin and glucose, this pathway stops. Giving these two stops the heme synthesis, which make perfect sense. When do people present with acute intermittent porphyria? When they go through heme synthesis, right? So how do you help them? Don't let them go through heme synthesis. If you inhibit their heme synthesis pathway, they won't have to go through that. The problem comes when they go through. Is everybody clear, folks? So what do you have to do to the patient? You always have to maintain their heme level properly. So you have to give them from outside. If their heme level is good, they will not have to go through their heme synthesis. Is everybody clear, folks? Okay. So it's like a glycogen storage disease. When do they produce symptoms in glycogen storage disease? When they fast, isn't it, folks? What's the treatment? Don't let them fast. Frequent starch, right? Same story. If they don't go through heme synthesis, they will not produce this symptom. So when we give glucose, this is the question. 9 out of 10 students failed. When they ask you, giving glucose to a patient with acute intermittent porphyria, how does it help? How did it help? Everybody were like, oh, it affected the porphobilinogen deaminase. Wrong answer. It's shut down here. First pathway, first step. Now take a look at here. Even though acute intermittent porphyria is a deficiency of this enzyme, but when we give glucose hemin, it's actually downregulate ALA synthase. Is that clear, folks? I repeat this. Even though this patient with acute intermittent porphyria, they have a deficiency of porphobilinogen deaminase. But when I treat them with glucose, the glucose downregulate ALA synthase, so we stop right here and we don't go further. Is that clear, folks? Students jump and pick this as an answer. I understand. The question didn't ask where the problem. The question asked when you treat, how does the treatment works? Is that clear, folks? Are you guys following me? So even though the problem is porphobilinogen deaminase, when we give glucose, the glucose downregulates ALA synthase. So we are blocking this, which means we don't move forward. If you don't move forward, no problem. Is that clear, folks? All right. I'll show you that question. UWorld has it now. Now, the next disease, Porphyria cutanea tarda. Very similar to the first disease what we just studied, only different is they involve the skin. That's all it is. They have skin involvement. The first one, acute intermittent porphyria, don't have the skin involvement. Is that clear, folks? Look at the enzyme. Next step. This one is gone. Uroporphinogen decarboxylase. So you back up this. They just have blistering cutaneous photosensitivity and hyperpigmentation. That's a skin, folks. Okay. Most common porphyria, look at that. That's a most common, which means you most likely have that on the exam because that's a most common one. It's like how most common inherited bleeding disorder is. Von Willebrand. Most common inherited clotting disorder is factor V, right? All right. I'm scared to ask. Now, that's this one, folks, okay? This is the most common cutaneous, okay, the porphyria here. Exacerbated with alcohol consumption. When they drink alcohol, this can be exacerbated. It's a familial and some other disease. We avoid the sun and phlebotomy and all these things, okay? Now, those are the 2 diseases and 2 steps, folks, okay? Now, there is one more disease on the top, lead poisoning. Let's talk about lead poisoning. That's easy. Lead poisoning, let's clean this up. Lead poisoning is happening either you don't have ALA dehydratase or you don't have ferroketolase. They cannot ask you which one in the exam by giving both. They could only give you one of those 2, folks, okay? But if they still, let's say if somebody write like that, most commonly ferroketolase than ALA dehydratase. okay? But they cannot give you that. Now you look at this, enzyme affected ferrochelatase and ALA dehydratase. According to the enzyme, you will have material backing up. If it is a ferrochelatase, you have more protoporphyrin. If it is ALA dehydratase, you have more ALA. Is that clear, folks? So that's lead poisoning. People get microcytic anemia. Highlight the word basophilic stripling. I'll talk about that in a moment. And it can affect GI, kidney, everything. Children, exposure to lead paint, especially on houses, I think that was built before 1975 or something like that. That gives you mental deterioration. Okay, this lead goes to the brain and stuff, folks. Environmental exposure. Look at this headache, memory loss, demyelination. All these symptoms can be an effect of lead poisoning. Okay, so we only check lead poisoning in those kids who lives in the neighborhood. Those houses were built before that, folks. If not, we don't. But that is your heme synthesis and lead poisoning. Is that clear, folks? Let's do question in that heme synthesis pathway so we would not forget the key.